Today, I'd like to share with you some work we've done in the past looking at ciliary respiratory dysfunction in congenital disease patients with heterotaxy, specifically addressing whether they may have undiagnosed PCD. Congenital disease patients with heterotaxy are well known to suffer higher morbidity and mortality that is associated with post-surgical respiratory complications. And so relevant to this is, in fact, the knowledge that airway clearance and left-right patterning both require multiciliary function, as shown here. Respiratory epithelia from the nasal epithelia of a human subject, you can see normal coordinated beating motion that is responsible for mucociliary clearance. And then on the right, you can see a mouse embryonic node with monociliated cells that show this rotary motion across the surface of the node in the early embryo that establishes a gradient from right to left that is involved in setting up the left-right body axis. So multiciliary function in both of these contexts play an important role. In the left for mucociliary clearance, and the right for setting up the left-right body axis. So this suggests that, in fact, heterotaxy patients could, in fact, have respiratory dysfunction from multiciliary defects, and that same multiciliary defects may explain the heterotaxy those patients exhibit. So this then leads us to the question whether, in fact, these heterotaxy patients might actually have undiagnosed PCD, primary ciliary dyskinesia, which is a disease associated with multiciliary defects. So PCD, as you know, is due to mucociliary clearance defect due to respiratory multiciliary defects, and they can have cartilaginous syndrome, ascites versus totalis, or heterotaxy of randomized situs. And PCD is now known to be a monogenic recessive disorder with more than 40 PCD genes identified that's important for multiciliary function. And so here are some examples of what PCD might look like. This is in a mouse model PCD. On the top is the tracheal airway epithelia of a wild-type mice. You can see normal cilia beating motion that's coordinated. On the bottom are the airway epithelia from a mouse with a DNH5 mutation. So this is a PCD model. You can see many in multicilia and some slow dyskinetic motion of some of the cilia. And this is from a top-down view where you can see the same, but in different perspective. And then on the right-hand side is, in fact, the same video that you saw earlier from a wild-type embryo showing multicilia in the embryonic node. On the bottom actually is a video also playing of the cilia from a DNH5 mutant mouse. And if you look carefully, you can see these toothpicks across the surface of the node. Those are cilia that are immotile in this DNH5 mutant. So this is multiciliary defects, both in the airway, the node, in the context of PCD. And here's just an example of a PCD patient with EC65 mutation, showing in this case stiff motion with incomplete stroke associated with the nasal epithelia cilia. This is a little unusual because most PCD patients show more immotile cilia and with only very poor movement of some cilia. So this is more a motion that we normally see. So to address the question whether in fact heterotaxy patients have undiagnosed PCD, we recruited patients with congenital disease with heterotaxy from Children's National Medical Center in collaboration with Dr. Linda Leatherberry, recruited 45 subjects and conducted 2 tests to determine whether they have PCD. This includes conducting a nasal scrape to obtain nasal epithelial tissue to do video microscopy to look at ciliary motility. And we also measure nasal nitric oxide levels from the nasal sinuses, which is typically very low in PCD patients. And so here are the video microscopy obtained from the nasal epithelial tissue of 3 heterotaxy patients on the bottom. This is that same video you saw of a known subject. You can see there's asynchronous motion, stiff incomplete stroke. This is actually somewhat reminiscent of that CCD-C65 subject. And here is a patient that shows abnormal ciliary motion that we would describe as wavy. So out of the 45 subjects, 18 of them actually show ciliary dysfunction. So 41% showing this very high prevalence of ciliary dysfunction amongst the congenital disease heterotaxy patients. What we noted is that most of the heterotaxy patients actually retain very significant amount of cilia motility, but the motion is very abnormal. And as I said, this contrasts with more immotile dyskinetic cilia with limited range of motion in PCD patients. So we also measured nasal nitric oxide, as I mentioned. And what we found is that in patients with ciliary dysfunction, they exhibit very low nasal NO. So this is measuring nasal NO in nanoliters per minute. So we just look at the bottom right, look at subjects that are greater than 6 years of age. And these are patients with ciliary dysfunction, PCD, A, B. And then here are the controls, and here are the congenital disease heterotaxy patients with normal ciliary motion, and here are the PCD subjects. And you can see the PCD subject had very, very low nasal NO. And we can see that those with normal ciliary motion look very much like control, which is much higher than the PCD subjects. But in the ones with ciliary dysfunction, we can see that they have much lower NO. And in fact, this category of patients show NO levels that are near the PCD levels, although mostly they're still higher than that of the PCD subjects. So what we find is that the patients with ciliary dysfunction do have reduced NO levels, but they are mostly all above the PCD cutoff value, which is 77 nanometers per minute in subjects 5 years and older. So to further explore whether they may have any evidence for having PCD, we did whole exome sequencing analysis of 25 of the heterotaxy CHD subjects and looked for mutations or variants in known PCD genes. And in fact, we found no compound heterozygous or homozygous mutations or variants in known PCD genes. 2 of the 13 heterotaxy CHD patients with ciliary dysfunction actually did harbor variants in known PCD genes. One patient actually had a heterozygous mutation in a known DNA I1 founder, actually has a heterozygous known DNA I1 founder mutation. Because it's heterozygous, of course, it cannot cause PCD. We also had another patient that had 2 heterozygous rare variants, one in DNH5 and one in DNH11, both PCD genes. But again, because they are heterozygous, they do not fit the classic model of a monogenic recessive disorder for PCD. So presumably by themselves, they cannot cause PCD. We also sequenced additional heterotaxy CHD patients that were recruited from Children's Hospital Pittsburgh. This is after I moved to Pittsburgh, and found that in fact, these additional heterotaxy CHD patients, none of them actually have compound heterozygous or homozygous mutation known PCD genes. So really show that in fact, the classic genetic model for PCD does not fit what we observe in heterotaxy CHD patients. And in fact, it would suggest that there's probably more complex genetic model of disease underlying the ciliary dysfunction in PCD in the heterotaxy CHD patients, and that it may involve oligogenetic interactions, perhaps including between PCD and non-PCD cilia-related genes. So overall, then these findings suggest that the heterotaxy CHD patients' ciliary dysfunction actually have phenotypes that don't conform to classic PCD, and they're not likely to have undiagnosed PCD. And so this, in fact, is supported by the findings from the Mucociliary Clearance Consortium, where they conducted a large retrospective study and then also a prospective study that showed the incidence of heterotaxy and heterotaxy congenital disease among PCD patients is very low. So for heterotaxy, it's 6.3% in the retrospective study, 12.1% prospective study. And for heterotaxy with congenital heart disease, it's very low, even lower, 2.3% in the retrospective and 2.6% in the prospective study. So this is consistent with why when we looked at heterotaxy CHD patients, we really found no examples of PCD, that in fact, PCD patients with heterotaxy congenital heart disease is very low. And so this finding is kind of surprising because we have looked at several dozen mouse models of PCD in my lab over the years, and we show that they all have a high incidence of heterotaxy. So in a DNH5 mutant model, data shown here, we can see 40% have heterotaxy, 25% status solidus, 35% status inversus. So generally, we see nearly half of all the mutants in any PCD line will have heterotaxy. And then we see that, in fact, congenital disease is typically only seen in the mutants with heterotaxy. And in fact, almost all the mutants with heterotaxy will typically have complex congenital heart disease. So this finding is quite different with what's seen in the PCD patients in the study that I just showed you earlier. And so for the observations from the PCD patients together with the mouse data, we would suggest that there's a depletion of heterotaxy and heterotaxy with complex CHD in the PCD patient population as compared to what we know is observed in the PCD mouse models. So this would suggest that human fetuses with heterotaxy CHD harboring PCD mutations may be dying in utero and are not represented in the clinical population. And I should mention that in our analysis for heterotaxy in our PCD mouse models, we typically are harvesting the fetuses before birth. And that is to make sure that, in fact, we don't lose any of the animals that are born, because if they're born dead, oftentimes the mother will eat up the pups. And so we really won't know what the distribution of phenotype is. So in fact, it is important to note that our analysis is also done with fetuses harvested in utero. So consistent with this notion that fetuses, human fetuses with heterotaxy CHD may in fact be lost or dying in utero, is in fact that it's been reported that there's very high intrauterine death of around 30 to 60% in human fetuses with heterotaxy and complex congenital heart disease. So these are really depleted and underrepresented in the PCD patient population. So then we believe that based on these and other findings, that heterotaxy CHD patients probably don't have classic PCD, but we propose that they may have a variant type of ciliary dyskinesia, or maybe we might refer to them as having BCD, and that this ciliary dyskinesia, a different type, may actually cause milder respiratory symptoms and disease. And I say milder because we typically don't see neonatal respiratory distress in newborn congenital disease patients with heterotaxy, even though they may have ciliary dysfunction. And so we think that maybe respiratory symptoms of disease could be exacerbated by the surgical procedure for palliation of the congenital heart disease, and that this is what underlies the increase in post-surgical respiratory complications. And so to see if in fact this ciliary dyskinesia is indeed associated with increased respiratory complications, the subjects that we looked at previously in Children's National Medical Center, we followed up to look at post-surgical outcomes. And you can see that those with ciliary dysfunction show more in the way of respiratory complications compared to those without ciliary dysfunction, p-value 0.006. They also show increased total tracheostomy, as well as increased use of inhaled beta agonists, which indicates that in fact they do indeed have respiratory problems, and that the use of a bronchodilator is needed. And so indeed, ciliary dyskinesia in heterotaxy CHD patients are associated with increase in adverse post-surgical respiratory outcome. So of course, one thing that we don't know is whether this increase in adverse respiratory outcome is really related to the role of cilia in mediating mucociliary clearance. And in order to address that question, we really have to measure mucociliary clearance in these patients. And so in collaboration with Tim Tokaran, a biomedical engineer in the Department of Medicine, and Philip Adams, a critical care anesthesiologist, we developed the ability to measure mucociliary clearance in infants in the CICU. So Tim developed the use of a nasal cannula to deliver technetium sulfur colloid into infants that undergo congenital cardiac surgery. And then this deposits the radioactivity in the airway and the lung. And then a portable gamma camera is placed above the infant. And then over a 30-minute period, 1 minute scans are conducted to measure radioactivity in the lung and airway. And with this, then we can measure airway clearance, and this is at T0 and 30 minutes later. And you can see this radioactivity in this region of the lung is cleared over that time frame. And so if you look at preoperative scans, you can see there's a great deal of airway clearance. And that's shown here for a single subject over time. Over 30 minutes, you can see that radioactivity is decreasing because it's being cleared from the airway. However, postoperatively, if you do a similar scan, you can see there's little or no airway clearance. So essentially, what we found is that within 20 to 48 hours postoperatively, we cannot detect any airway clearance in these patients that have undergone congenital cardiac surgery. However, interestingly, after 48 hours, we begin to see divergence into airway clearance between different subjects. So in preliminary, or I should say in pilot study, we looked at pre-op mucociliary clearance and then look at how it relates to post-op respiratory support. And what we find interestingly is that the higher the pre-op mucociliary clearance, the lower the need for post-op respiratory support in the way of mechanical ventilation days, or in the need for non-invasive positive pressure ventilation days. And so this really supports the notion that pre-op mucociliary clearance function indeed plays an important role in predicting post-op respiratory outcome. And that in fact, this pre-op mucociliary clearance indeed is related to the post-op respiratory outcome. So in conclusion then, patients with congenital disease associated with heterotaxy do indeed have a high incidence of ciliary dyskinesia, but we think this is largely distinct from PCD, and such ciliary dysfunction can increase the risk for post-surgical respiratory complications. We think that further studies are clearly needed to explore the role of ciliary dysfunction in post-op airway clearance function, and that indeed we would like to measure how airway clearance function may be related to ciliary motility. And then we also think that it might be worth pursuing looking at the potential benefit of perioperative pulmonary support and reducing post-op respiratory complications in heterotaxy congenital disease patients. With this, I'd like to thank you for your attention and many people that contributed to the work. I'd like to especially acknowledge 4 very talented fellows that over the years have contributed to this work, including Nita Knocklick, Andrea Garrard, who I believe is participating in this symposium, and Eileen Stewart, Philip Adams, as well as help from Timothy Corcoran, the faculty in the Department of Medicine that developed the MCC scan, as well as pulmonologist Daniel Weiner, Jeff Curlin, the design of our experiments, and of course, Linda Leatherberry, and also the Mucociliary Clearance Consortium, Michael Knowles, McGee Lee, Adam Shapiro, Mamuna Sarawala, that played an important role in getting us